on the horizon and what are the algorithms that we use currently. Can I have my slides up on the screen, please? Yes. So between now and quickly before the next session starts, and then if any of you have any questions, we can quickly take them. I'm very fortunate to work with a large group of clinicians and researchers at the LV Prasad Eye Institute, and who work on ocular surface stem cells and corneal regeneration. And most of the stuff that I'm going to present is on their behalf, not insights that I have gleaned myself alone, but I've been very fortunate to work with this large group of talented people who have helped me in learning and treating our dry eye patients better. So I'm going to share that insight with you. We have also benefited a lot from collaboration. So we work very closely with other academic institutes in the country. So one of the fruits of this collaboration was the dry eye special issue that we published in the Indian Journal of Ophthalmology. So for those of you who have not accessed this yet, this is the April issue of the IGO in 2023. All of the articles are open access, and it's a huge collection of over 60 papers. Many of them are consensus criteria and management algorithms from different types of dry eye disease. And what I would like all of you to understand and maybe take from my talk is that when you're treating dry eye disease, please treat these people as human beings and not just as patients that you have to check out of your OPD. Treat the diseases and not the diagnosis. So it's not so important as to label them in one way or the other, but to help them get relief from their symptoms. And that's again important that you treat the symptoms and not just the signs. So don't always try to chase what you're seeing on the slit lamp, but try to give relief to the patient in whichever way that can be done. And as much as possible, collaborate and work together so that you treat together and not alone. Okay. For those of you who are interested in aqueous deficient dry eye disease, which is far more common in India than it is in the West, this is a very helpful and guide or review article on preferred practice patterns on aqueous deficient dry eye disease, which we wrote with our collaborators in the US, that you can access from this special issue, which will help you in going about. There's a new criteria for classifying causes of aqueous deficient dry eye disease that we have proposed here, which you will find very useful. Similarly, we also have a preferred practice pattern on evaporative dry eye disease, which again can be very challenging to treat, can be very frustrating to treat, and you have these patients who are unhappy, particularly if they've had refractive surgery. So what do you do about them? There's a very nice a part of this article is dedicated to patient counseling, and I think that many of you will find it very useful. And something that is not very commonly discussed, but it's also very important, like we were talking about in the morning, a lot of the aqueous deficiency and otherwise dry eye disease has underlying autoimmune and immunological conditions for which you need to use both topical and systemic immunosuppression. And you need to understand, there is a method to this madness. It's not that you throw whatever is at hand at your patient and see what works. So what is the logic behind choosing a particular anti-inflammatory drop, a steroid eye drop, or systemic immunosuppression is very important to understand and use that logic to guide your approach. Okay, so I'll take you through a couple of cases. This is a data scientist with prolonged screen time, burning sensation in both eyes with corneal staining. It's very easy to diagnose this case. So these are the myography images from the upper and lower lids. This patient obviously has evaporative dry eye with a nid bud of 6 to 7 seconds, and you're going to treat this patient as a patient of meibomian gland dysfunction, evaporative dry eye. And this is a slightly more severe case, very similar history with similar nid buds, very faint corneal staining, and you can see that the meibomian glands are slightly more deranged. But then this is a female patient who has almost 50% of absent glands, and this is another female patient, very similar profile, who has almost no glands. All of the glands are atrophic. This is, all of this is along the spectrum of evaporative dry eye and meibomian gland dysfunction. But you must understand that while certain therapies like LipiFlow, etc., might work in the first couple of patients, they will not work in these patients. And the reason why you have such extensive atrophy in these patients are because they're female patients, and these two patients had multiple other comorbidities which were in the form of dermatological issues. One had acne and was using anti-acne medication, and the other had PCOD and was using hormonal replacement therapy for that. And you can see this in perimenopausal women also. Hormonal replacement therapy and treatment, sometimes treatment for acne, severe acne, is hormone replacement therapy, and it can cause atrophy of the meibomian glands in the same way that it causes atrophy of the sebaceous glands, which basically cause acne. And it is to a very large extent irreversible. But you must, diagnose this correctly, and therefore mammography becomes very helpful. But you must also not unnecessarily do lipiflow in these patients or IPL in these patients, because that will not help relieve the patient's symptoms. So this is important to consider. Of course, the patients will benefit from lubrication and blinking and warm compresses and lipiflow and IPL and thermoflow. What is important to understand is that these are not one-time fixes. It's not like collagen cross-linking for keratoconus, and it's very difficult to have a sustainable economic model where you can just do this once and then benefit from that. These patients will keep coming back with symptoms. It's very important to understand a lot of counseling is involved, and you need to explain to the patient that it needs to be repeated. And mammography, I think, is particularly useful if you're going to use these therapies, because it at least tells you about those cases where it is not going to be useful. And of course, in patients with meibomian gland dysfunction, especially if they're young females, please take a history of acne and also for PCOD, etc. For diagnosing for aqueous deficiency dry eye, we had this presentation in the morning by Dr. Rashmi, and she showed that the lacrimal gland evaluation is very useful. This was initially described by Dr. Swati Singh from LVPI, that you can pull the lateral canthal tendon, expose the palpebral lobe, stain it with a fluorescein strip directly, and you can see the aqueous outputting. This is a very easy way to confirm the diagnosis of aqueous deficiency, also to differentiate it from evaporative dry eye and other forms of dry eye disease, where you know that, okay, this is a problem with the lacrimal gland, and institute therapy, instead of being in a gray zone and not knowing whether it is lacrimal gland or the meibomian gland at fault. It's a very useful test. The only caveat here is that don't use topical anesthesia before you do this test, because topical anesthesia inhibits the reflex arc, and you can misdiagnose these cases as aqueous deficiency, although they have absolutely normal functioning lacrimal glands. It's also useful to differentiate this test not only between evaporative and aqueous deficiency, but different forms of aqueous deficiency, particularly cicatrizing conjunctivitis. Here, the role of anti-inflammatory therapy is important, because a lot of aqueous deficiency is because of underlying immunological causes, and you would also need to collaborate with the rheumatologist. One important caveat that I would like to mention is many patients who are misdiagnosed or wrongly diagnosed as aqueous deficiency essentially have hypofunction because of a delayed reflex, because they are on some kind of antidepressants or anxiolytics and neurological medications. You can also have situation where they have aqueous deficiency because of scarring around the lacrimal gland area, because they're using anti-glaucoma medication. So please check for these things as well. So if you can stop these medications that are causing this manifestation, then the patients will benefit from your therapy. Otherwise, they'll just keep having the symptoms. When you're diagnosing aqueous deficiency, usually these patients will have dry mouth or joint pains. They might have a history of allogenic hematopoietic stem cell transplantation. If it's a GVHD case, they have skin or mucous membrane involvement. There may be conjunctival cicatrization. Usually you see interpalpebral SPKs, low Schirmer's, which is not really very reliable, but it can still guide you. And you see fewer openings on direct assessment of tear function of the lacrimal gland, and a low TMH and NETBUR. And this is usually the criteria that we use for diagnosing aqueous deficiency. So I'll just show you a couple of cases that presented with aqueous deficiency. This is a case, and you can see this interpalpebral staining. This tells you low Schirmer's. On a workup, this was a patient with secondary Sjogren's, because the patient had a elevated anti-CCP and rheumatoid factor, because the patient essentially had rheumatoid arthritis. A similar case where, again, you can see very faint interpalpebral staining, and this is a case of primary Sjogren's syndrome, when the anti-Rho, anti-La antibodies are raised. And both of these cases would need referral to a rheumatologist and immunosuppressive medication. A very similar case, again young female, which also shows some form of interpalpebral staining, but this staining is slightly and subtly different. You see that in the right eye, only the nasal half is staining, and in the left eye there is a band of interpalpebral staining, but there is also staining near the superior and inferior limbus. So this is not typical of aqueous deficiency. There's obviously something else that is going on, so you have to be a little bit more suspicious, and that's why I say, fluorescein staining is one of the most important, valuable tests that you can do in pre-op or in the evaluation of these ocular surface disease patients. Here, if you flip the eyelids, you will see that the patient also has lid margin keratinization, and the reason that you see these changes on the ocular surface is because of lid-related keratopathy, and the patient actually has Stevens-Johnson syndrome. So here, anti-inflammatory therapy and treating this patient as a primary or secondary Sjogren's is not going to work. The patient does not need to be referred to a rheumatologist. The patient would need either scleral contact lenses or mucous membrane grafting for addressing the lid pathology. So these kind of diseases under the umbrella of chronic cicatrizing conjunctivitis, under which SJS falls, there's a diagnostic algorithm. We had a wonderful session in the morning. It was very well attended, and we had a lot of discussion on how these conditions can be managed. There's also a very useful review article. Again, this is in the Indian Journal, written specifically for the Indian audience, that you can refer to understand what is the diagnostic logic that you need to use to approach managing these cases. So this is typically what SJS looks like, but you can also have something that looks very similar but is more ominous and more dangerous, which is pemphigoid. This also sometimes is very commonly misdiagnosed only as dry eye and treated for several years only with lubrication. These are patients who would need a conjunctival biopsy confirmation of the diagnosis, immunomodulatory therapy. Otherwise, it is a chronic, progressive, and bilaterally blinding disease, which almost has no cure once the end-stage disease develops. Very, very difficult to treat, and therefore the crux of treating this condition lies in its early diagnosing and institutional immunomodulatory therapy. So when you have a patient with bilateral aqueous deficiency disease, please pay careful attention to the medial lateral canthus, the tarsus, the inferior superior fornix, to look for signs of cicatrization. Otherwise, you might miss a case of cicatricial pemphigoid very early on, when intervention is most likely to have the best beneficial effect. A strong mimicker, a very close mimicker of mucous membrane pemphigoid is drug-induced cicatrizing conjunctivitis, most commonly caused by anti-glaucoma medication, eye drops, particularly those which are preserved, also particularly preserved anti-glaucoma medications, but it can also happen with non-preserved anti-glaucoma medications, as the molecule itself is often responsible. Combination of BAK, of course, is very toxic. There are certain clinical signs that can help you in the diagnosis. Periocular pigmentation is one. This is because the puncta gets stenosed very early. The drop keeps overflowing, and it causes contact dermatitis around the periocular skin, which results in these pigmentary changes. So there's a very good review again in the dry eye issue on drug-induced dry eye, which I think you will find very useful. We should look at all the various medications that a history of which needs to be asked, so that you can just stop these medications that it usually relieves the patient of their symptoms. Punctal changes are usually an indicator that something is going on. It can be punctal edema, it can be punctal stenosis, you can have granulomas around the punctum, or you can have keratinization. You can even have fibrotic bands which are forming between the upper and lower puncta. All of these indicated there is some amount of toxicity that is happening. This usually happens because the puncta is the area of the eye where you have maximum contact with the medication, because all of these eye drops are draining through the puncta. You can also have this kind of very typical keratinization, which is restricted to the nasal half, again because the eye drop mostly collects in the nasal half of the eye near the cul-de-sac. You can also have very severe conjunctival cicatrization, which is usually more inferior than superior, more nasal than temporal, and you have this zipper-like symblepharon. If it is particularly unilateral and the patient has a history of using anti-glaucoma medication, you really need to consider this as a diagnosis. Conjunctival biopsy will rule out pemphigoid and will help you confirm the diagnosis. Treating the underlying cause without using eye drops, stopping the offending medication, using preservative-free lubricants, anti-inflammatory therapy will, if you intervene early, you can prevent long-term damage and save these eyes, as you can see in the before and after photographs in the top and bottom row. These are patients in which the eye drop was stopped and an alternative was started. It is sometimes very challenging to treat the glaucoma, because if the conjunctival cicatrization is very severe, then a trabeculectomy will not work, and the glaucoma surgeon might need to do a valve. This is a patient with bilateral nasal canthal cicatrization, which looks very odd. A patient has been using an Ayurvedic medication for, this was a patient who was using, was diabetic and was using some Ayurvedic eye drops, but that was not the cause in this case. What was the cause? This was initially suspected that is what was causing the cicatrization, but it was actually systemic gliptins, oral gliptins that the patient was using for her type 2 diabetes. Gliptins, any kind of gliptins, are known to cause a condition which is known as drug-induced bullous pemphigoid or gliptin-induced bullous pemphigoid, and it can present with ocular cicatrization also. Patients also have ulcers in the mouth, they have pruritic lesions on the skin, and usually this starts about 1 to 2 years into using the gliptins. And so this is something that also you need to ask a history of when you're seeing patients with cicatrization and dry eye. So drug-induced dry eye is more common than you think. It's frequently missed and undertreated, and it can lead to severe sequelae. Make sure you take a history, like I said, of other medications, the neurological medications, also of topical and systemic medications. And my final few slides on what is the algorithm that I use, logic that I use in treating the patients with dry eye disease. So this is basically what you have at your disposal. You have lubricants and you have anti-inflammatory eye drops. We do not have lifitegrast yet in India, but I think it is being launched either this month or next year. We do have the other combinations and molecules in isolation. So this is how all of them work. Again, you can look at this wonderful review article that we put together, which describes exactly how all of these medications work. But this is usually the logic that I use when I'm treating patients with aqueous tear deficiency. The main drop that I depend on is a carboxymethylcellulose 0.5%. The main reason is because it requires frequent administration, and in India this is price controlled. So it is the cheapest medication that you can get as lubrication, and you have to understand this is a chronic condition. Patient has to use this lubrication for a very long time, and sometimes they get fatigued. It may not also be economically sustainable for them to be using lubricants for a very long time. So please don't prescribe to your patients hyaluronic acid or polyols or hypermelose 1 hourly. It is simply patients struggle to afford this. CMC 0.5% is the drug that you could go to. I don't care which brand you prescribe, but this is price control in India, something that the patient can keep using, and therefore you will have compliance. Otherwise, patient will just stop using the drops after some time and come with more serious complications, which are much more difficult to deal with. And usually in aqueous tear deficiency, along with sending the patient to the rheumatologist for the systemic medication, we also use topical cyclosporin, which works very well. We also have topical tacrolimus in India, which is the advantage, and you can use that at night. And usually we prefer preservative-free cyclosporin. So there are a lot of options for preservative-free cyclosporin now in the Indian market. You have the conventional concentrations 0.05%, and you also now have 0.09%. So I think that these are excellent medications that you can resort to and you should use in patients with tear deficiency. In evaporative, like I said, there are other things that you can help you more, and medications that do not directly address the underlying pathology, but usually you use something more viscous so that evaporation is less. And anti-inflammatory medication do not have so much of a role in treating evaporating dry eye disease. So to conclude, choose the right therapy. I think establishing the cause, differentiating between meibomian gland dysfunction, evaporative and aqueous deficiency is very important. The spectrum is very wide. It can be simply meibomian gland dysfunction driven evaporative dry eye, or it can be Sjogren's or complex cicatrizing aqueous deficiency. There's a lot of cicatrizing conjunctivitis in our country that leads to dry eye. This is something that you should pay attention to, have a high index of suspicion for when you particularly see a patient of aqueous deficiency. There are a lot of topical and systemic medications that can cause dry eye. Please take a detailed history and rule them out. And my approach typically in these cases is to confirm that the patient has dry eye, number one, to type whether it is aqueous deficiency, evaporative or mixed. Usually it is one or the other. Both glands are typically together, not involved as much. It's usually very different, the spectrum. And then based on the cause, treat. Most patients will need a combination of eye drops and a lot of counseling. So you have to give, if you are doing a dry eye practice, you must be prepared to give the patient a lot of chair time. And like I said in the beginning, treat the patient, treat the symptoms. And if you are in the business of managing ocular surface disease and ocular surface patients and dry eye patients, you must collaborate with others. You must collaborate with your colleagues. You must collaborate with a rheumatologist, dermatologist, and even in some cases when you're treating patients with GVHD, with an oncologist. So without that collaboration and that network, it's almost impossible to treat these patients completely, comprehensively. Thank you so much. I hope the people for the next session are here and ready to take over. I have done my job. And if anybody has any questions, you can get hold of me wherever I am and ask me, and I'm happy to answer. Thank you so much.
Good evening, everyone. Sorry for the delay. This is the Eye and Contact Lens Association session. My name is Vishal Janji. I'm the current president of the Eye and Contact Lens Society. This is going to be a mixed cornea session. We have excellent international faculty with us. I would like to invite the panelists, Dr. Sonal Thuli, Dr. Shizuka Ko, Dr. Divya Srikumar, and Dr. Amit Gupta. Without further ado, we're going to start with the first talk. We have the pleasure of having Professor Shigeru Kenoshita from Japan, and he's going to tell us about science and technology underpinning corneal endothelial cell transplantation. Professor Kenoshita, please. Yes.
Well, once again, thank you very much for including me as one of the speaker. I'd like to talk a little bit about the cultured corneal endothelial cell transplantation. We have some of the progress. There are several financial disclosures to make. One of them highlighted in block letters are relevant to this presentation. When we are talking about the cultured corneal endothelial cells, that is culture from the in vivo healthy corneal endothelial cells, that's for sure. But in vitro, when we culture, these cells are heterogeneous. So we are targeting the mature differentiated corneal endothelial cells among them. How to do this? I think cultured cells highlighted in blue, that is a target for the cells for cell injection therapy, not highlighted in red. Highlighted in red is a kind of a cell state transition, fibrosis, EMT, senescence, or something like that. And then based upon the FACS analysis, we can clearly differentiate these culture cells highlighted blue are CD24, 26, 44, 105 negative, and then we try to create these culture cells for over the 90% of the population. These cell surface markers are expressed at CD44 negative. These cells are energy metabolism pathway is more toward the TCA cycle, and then red cells, they are more towards to the glycolysis pathway. So not only see the cell surface marker, that could tell us their mitochondria is normal, healthy, or somewhat abnormal or malfunctioning. So I think I'd like to show you the one video that is already published in ophthalmology as a supplemental video. And because of the corneal endothelial failure, I think we marked the 8 millimeter in diameter, but it really doesn't need it. But for the comparison of the corneal endothelial cell density as a long-term basis, we tried to compare the removal of the endothelial cells at the 8 millimeter diameter. So 1.6 millimeter incision, and then try to scratch the surface of the posterior cornea. That means on the Descemet's membrane. We try not to remove the Descemet's membrane, scratched something on them. Something means extracellular matrix or some of the degenerated endothelial cells, and then try to move the horizontal fashion of using the silicone needle, and then using the vision blue, and then that could stain the posterior surface of the cornea. And by looking by ourselves, human eye is more sensitive, so therefore we can easily tell where I removed or where they stained them. And then one stitches, and then using that 30 gauge or 32 gauge needle, try to remove the most of the ACUS humor from anterior chamber and collapse the anterior chamber, and then using the 26 gauge needle, inject the cells as a suspension. Total volume is 300 microliter. That solution includes 1 times 10 to the 6 of the cultured cells, and also with some of the low kinase inhibitor in them. And then immediately after the surgery, we ask the patient to face down position for 3 hours. You can easily see the formation of the anterior chamber. So, and we published the 2 papers, 2 years data and 5 years data of the initial 11 cases. So far, so good. Cornea is clear and the corneal thickness become within a normal range, and the endothelial cell density is at least over the 1,000 cells per square millimeter or so. So this is the initial 11 cases up to 5 years post-operative. ECD is about 1,200 cells per square millimeter. These data is almost the same or close to the data obtained from the DSEC or the DMEC published elsewhere. And this is the 2 representative cases of the patient 1 and patient 2. We followed up to 10 years, but this is a 9 years the picture. Cornea is still transparent. Corneal thickness is almost the same within a normal range. It's not like a DMEC. DMEC sometimes immediately after surgery they become I think thinner and then gradually coming back. But this cell injection, the corneal thickness is constant within the normal range, and the endothelial cell density is about 1,000 cells per square millimeter at 9 years post-operative. And then we compare. Group 1 is we called first generation. Group 2 is a second generation. And what's the difference? Difference is the proportion of the mature differentiated subpopulation of the cells. By looking under the microscope, we cannot tell the difference, but the FACS analysis clearly shows the difference. And then when we compare the endothelial cell density 1 year, 2 years, 3 years post-operative, post-injection, and then group 2 did show the way high endothelial cell density compared to group 1, DSEC, or the PK. And so this is the summary of each of the contact specular microscopic image. Group 1 endothelial cell density is okay, but also the shape is more like a endothelial cell after the corneal transplantation, including endothelial keratoplasty or PKP. But group 2 did show a very, I would say, the smooth, small hexagonal type cells. There's only one Fuchs endothelial corneal dystrophy included, but nonetheless, this number 12 is also reasonably good shape of this. And then this procedure could be performed, applicable in graft failure after the penetrating keratoplasty. And also, we could perform the cultured endothelial cells injected after the decimeter stripping only as well in a Fuchs endothelial corneal dystrophy. So, and using the phase 2 and phase 3 physician initiated the clinical trial on March 17, 2023 this year, Japanese MHRA officially approved Piznova, that is from the Orion Biotechnology Japan, as a regenerative medicine product for corneal endothelial failure. So we need about a year to set up the first patient approved after the government. So in Japan, we have performed 65 cases, but about the worldwide basis, we culture the corneal endothelial cells in Kyoto, our university, CPC, and then send it over to El Salvador, and Ed Holland's group and the US groups perform the corneal endothelial cell transplantation injection procedure in El Salvador. 89 cases. So in total, we have about 150 cases of the cell injection therapy. So this IOTA and Escaron is a more like a repetition study which we performed in Japan. So this is the 4 representative cases. You could see the quite the similar results they obtained. So therefore, they just started the clinical trial in the US as well. So what future discoveries rise on the horizon? We still have to do the several things. One is improved surgical procedures by manual technique or triple procedure with a DSO, and we have a limited cases, but we really have to prove that could be done. Also, mass production, we could do the mass production and donor selection of the cultured endothelial cells. But based upon the regulatory science issues, we have to overcome that. And also storage and transportation for cultured corneal endothelial cells. Freezing with the DMSO, that may be approved by the regulatory authority. We are not so sure. In this case, other freezing procedures is necessary. And also long-term maintenance of the cultured endothelial cell suspension, something like that. And also lock inhibitor eye drops may be beneficial post-operatively. Actually, clinical trial of the locus inhibitor called K321 by Kowa, Japanese company, that lock inhibitor eye drops application is now on the clinical trial after the DSO. Phase 2 clinical trial was already finished in the US, successful, and they are now going to the phase 3 clinical trial in the US and EU. This is an ongoing project, and Kathy Kobe, Friedrich Kruse, and many distinguished ophthalmologists are involved. Well, this is our Kyoto Prefecture University of Medicine, our group project, and thank you very much for your kind attention.
Thank you. That was a wonderful talk. Any comments from the panelists? Any questions? While we are waiting for Dr. Patel to get ready with his talk, I just have one question. How do you see the donor selection criteria? Like, are they stringent for the cases you've done so far?
We have an age restriction up to like a 25 years of age, and also over the, I think, 6 years of age, something like that. And then that's a donor selection. But we are still not so sure. They must have a very good selection for the donor cornea. It's not necessarily, I think, linked with the age. Even though 40, 50 years of age, they are a very good donor cornea endothelial cells. So,
okay, thanks so much. We'll take more questions towards the end of the session if anyone has any. The next speaker is Dr. Sanjay Patel from the Mayo Clinic. He's going to talk about the Fuchs endothelial corneal dystrophy clinical trials, designs, and outcomes. Thank you.
All right. Thanks, Vishal. So this kind of follows on from Professor Kinoshita's talk here about novel therapies for Fuchs dystrophy and how to test. Again, I have disclosures, again, none are related to the topic here. I am the developer of the VFuchs questionnaire that I'll mention. There's a lot of excitement right now in Fuchs dystrophy with novel treatments on the horizon, and that means approval of those treatments requires clinical trials. And some of those clinical trials are happening even right here in India, with at least 2 sites that I know of participating in active therapies currently. So where are we heading? We just heard from Professor Kinoshita on cell injection therapy, but there's a lot of other potential therapies out there based on the genetic aspects of Fuchs dystrophy. We just heard about primary dysmetorexis with ROCK inhibitor as well. So there's lots of different new agents out there. And unlike surgical advances in therapy, which do not require any regulation, so the evolution from penetrating keratoplasty to endothelial keratoplasty was not regulated. Obviously, anything here, anything pharmacologic or any other medical type intervention will require approvement, and that requires trials. So any clinical trial, you need to think about design characteristics and the outcome measures as well. So study design, the design has to be relevant to the clinical outcome. And that means thinking about the patient and what the patient is experiencing and what the patient needs to have improved. And then ideally, you would also relate this to some kind of pathophysiologic hypothesis as well, so that you can potentially relate changes in the tissue to changes in the actual clinical outcome. Outcome measures have to be objective, easy and acceptable to measure, and they have to be valid. And validity relates to the statistical aspects, and these measures need to be repeatable. You need to have some estimate of the variation within a population, should be without floor and ceiling effects, and outcome measures should be responsive to change, whether it's a change for the better or a change for the worse. And if they are responsive to change, that means a stable outcome measure does actually indicate stability, and that can be important in trials for Fuchs dystrophy. So specifically for Fuchs, I think every trial should address the state of the disease that is being treated, okay? Because it's not always well defined, and we'll get into that a little bit. There needs to be a stratified randomization as well. So are the eyes in each of the treatment arms similar? And ideally, you'd identify an enhanced cohort, a cohort that without intervention is otherwise likely to progress. And that's important because progression can be slow. And the slower it is, it means the duration of the study is going to be longer and therefore more expensive, less practical to do. So identifying the right cohort is important. So if we think about the pathophysiology of Fuchs dystrophy, I like to start with the patient because the patient is complaining about their vision. They don't like how they see. They want improvement in their symptoms. But the disease starts at the molecular level, and we've learned so much more about the genetic aspects. And this translates into endothelial cell dysfunction, okay, and not necessarily primarily endothelial cell loss. There is likely to be cell loss, but I think cell dysfunction is more of a primary feature here. And then in turn, that will lead to changes in the tissue, formation of guttae, haze at Descemet membrane, stromal edema, and you also get subepithelial haze, which can affect vision too. So then how do those relate to vision? We definitely know that stromal edema and subepithelial haze affect aspects of vision. I'm not convinced that we have good evidence that guttae themselves actually affect vision, and that's important about debating whether they actually need to be removed or not. So most of the outcome measures will be at the tissue and patient level. So if we kind of look at these a little bit more closely, just remember that Fuchs dystrophy encompasses a very wide severity of disease, but we're talking about corneas for these kind of clinical trials that are going to look more like this. You look at them at the slit lamp and there's no visible edema, yet the patients can be symptomatic with their vision. So can we actually measure endothelial cell dysfunction? And the answer to that is we can measure endothelial function. There are laboratory studies that you can do on human eyes in vivo. They take several hours to do. There's a fair bit of variability. They're not always practical for clinical trials, but I'm not going to get into that in the interest of time, but they can be done. Endothelial cell loss is often thought about as a good outcome measure, but as I showed this morning in the imaging session, it's not a good outcome because it's highly variable. The guttae create regional variation, there's sampling errors, and so you can get wildly different cell density measurements even within the same image of the same cornea as shown here. But also consider, here's an image, here's a cornea with Fuchs dystrophy, you can see guttae, and if you look closely, you can also see that there are cells still present. So just because guttae are there in your specular microscopy photographs and you do not see cells, doesn't mean that the cells are not there, okay? So cells are present, and it takes a while before those cell borders and the barrier function breaks down. But take a look at this cornea. This is a patient I actually had to do a cornea transplant on for pseudophakic corneal edema, yet they had a cell density of almost 2,000. So for most corneas, you wouldn't expect to be doing a cornea transplant, but this one needed it. And here's a penetrating keratoplasty that has a cell density of 371 and is clear and functioning, and the patient's happy with their vision. So cell density doesn't necessarily mean that cell function is impaired. There's a role for potentially measuring peripheral cell density. We know these cells can be important in repopulating the central cornea, depending on the type of hypothesis that you have. So there could be a role for that. Goutte can be assessed just clinically at the slit lamp. This is probably the best way to do it, but there is, again, a lot of variability, subjectivity, and I think if people use these, they should eliminate any reference to edema and grade that separately. Retroillumination is another way to try and objectively quantify, though this is also very variable. It's difficult to standardize between clinical sites. Potentially a little better is thresholding specular or confocal images to look at the guttate area. Haze or scatter is something that's often measured. It's often called densitometry. I'm not going to get into that because there is variability here as well, just in the interest of time. But I do want to talk about stromal edema because I think this is something that should be measured and should be quantifiable, and it can be quantified from tomography. I showed this image earlier this morning in my other talk. Tomography can pick up corneal edema at the earliest stage before it's visible by slit lamp. And I also showed this when you have findings on tomography, this predicts the prognosis, and this allows you to start defining the cohort of patients that you're treating, to stratify these patients to treatment arms, and to come up with an enhanced cohort, meaning a cohort that is likely to progress during the duration of the trial. So take these examples, which I showed again this morning. They had very subtle changes of corneal edema, and 6 years later becomes more obvious. So this is a sensitive tool. It could be used to detect progression, ideally even regression of corneal edema, but potentially stability as well. And ideally, we would take those images and quantify them, and you can do that. This is a set of eyes where we quantified their images and predicted how much improvement in corneal thickness they would have after DMEC surgery. And we applied this to a derivation group of eyes and then applied it to a separate group of eyes to validate this. And we had very high predictive power of 78% in a validation group. So potentially these images are quantifiable to allow you to start predicting what could be ideal. And finally, vision can be measured in multiple ways, from high contrast acuity, low contrast acuity, and that can be photopic or mesopic, and then something that's called stray light, which is a measure of glare, which these patients often have. And then finally, what the patients report themselves as a patient-reported outcome measure. So recommendations, if you're going to get into clinical trials, would be to really think about using tomography because it classifies the state of edema, stratifies randomization, defines an enhanced cohort, and potentially provides quick, easy, repeatable outcome measures. And so we talked about quantifying edema. Central corneal thickness is another way to do that. We could look at goutte, though beware of the caveats of measuring central. We could look at goutte and cell density, but cell density centrally can be a problem to measure. And then obviously the impact on the patient is going to be critical, but having tissue and a clinical outcome is important. So it's a interesting time to be if you're seeing a lot of these patients and getting into these studies. But thank you, Michelle.
Thank you. Any questions from the panelists or audience? Professor Kinoshita.
Yeah. May I have the question? I think there are, for instance, surrogate endpoint, visual acuity, intraocular pressure, or something like that. But in the cornea, there's not such a surrogate endpoint. I would say corneal thickness maybe, endothelial cell density maybe. But I think when we discuss with regulatory authorities, how can you explain or solve this as a primary endpoint? Always they are asking us the visual acuity is the primary endpoint, something like that. So,
Yeah, the visual acuity is a challenge if the patient is phakic, right? Because many of them have cataract in the cohort that you're measuring, so that can be a challenge. So you either need pseudophakic eyes, which restricts your population. Otherwise, I mean, people will often say looking at patients with minimal lenticular change, that can be a little challenging. So you may need to look for changes in vision, potentially quantify the cataract using a LOX grading. Regulatory authorities often want cell density and don't always understand the caveats of that. But it would be ideal if we can take tomography to actually quantify the edema and show that from one image to another there has been progression, stability, or regression. That would be ideal, but taking the subjectivity out of it, and unfortunately we're not there yet.
Yeah. Thank you. The next speaker is Dr. Sonal Tully. She's going to talk to us about gene therapy for anterior segment. Thank you. And while we are at it, so Dr. Patel, in the United States, we have a lot of patients with Fuchs and pseudophakia with 20/20 vision preoperatively, because you see all these guttae and haze and mild edema, but they can still read the chart nearly to 20/20, if not 20/25. So it's at best a sort of a remote surrogate marker. So I agree with you that something else, maybe tomography, has to replace that.
Yeah, you need something in the cornea to measure. You got to have something in the cornea to measure. And then just remember, this is not different from cataract. You can have 20/20 cataract patients who are still unhappy with their vision or struggling with night driving glare. It's the same, exactly the same.
Dr. Tully, sorry.
Thank you. No, you're fine. Could I have my talk up, please? Thank you. So good afternoon, and thank you, Vishal, and the organizers for giving me this opportunity. We're going to talk a little bit about corneal gene therapy, because that's sort of an up-and-coming thing. We treat diseases, but how can you actually let the body either heal itself or help it heal and solve the problem? I have no financial interest. I do have a patent, but it hasn't made any money, so I don't think I have any financial disclosures. So what is gene therapy? So gene therapy is basically you're delivering genetic material of some sort to targeted cells, and you're trying to correct some sort of a disorder, but usually a genetic disorder, but it can be others, as you will see. So what are the different things you can do? So if the body has got a genetic defect and is not producing a particular thing, if you give them a normal copy of that genetic material, they'll make that normal protein or whatever it is that they're not making. However, if they're making too much of something, or there's something that is causing a problem, like you'll see with the herpes studies that we do, or with some of the scarring studies, you want to cut that away so that it doesn't cause the genetic effects that it can. And then you can tweak some of the proteins so that they don't fold the wrong way, and that can be relevant for some of the corneal dystrophies. And then you can also not have a genetic defect, but use gene therapy to make the body produce things like anti-VEGF or interferon that might help it heal itself. And you don't have to use medication. So why did I get interested in this? So one of the faculty at the University of Florida, when I joined that, was Dr. Houseworth. He's well known in the genetic treatment area. And I saw this very cool video that he showed of this dog called Lancelot. And Lancelot was born with LCA, Leber's congenital amaurosis, a variant of that. And they used this gene therapy to treat one of his eyes. And you could watch him walking through the maze, and every time he would come to a barrier on the side that they had treated, he would navigate around it. And when he came to a barrier that he couldn't see on the eye that they hadn't treated, he would bump into it. It was really very interesting. And of course, now after 20 years, Luxturna, which is one of the disease, the treatments for LCA, is commercially available now in the US. And so I got interested in gene therapy and figuring out how do you deliver gene therapy. And so the way Luxturna is given, of course, is by using a vector called AAV, and we'll talk about that in a minute. But there are other ways to deliver genetic material into tissues and into cells. So you can iontophoresis it. You can use electrical shock, basically, to drive it into cells and into tissues. You can intrastromally inject it, and those are the big ways we treat that. So the first thing I got interested in was corneal scarring. So as you know, if you've done PRK or if you do PTKs, sometimes that laser can cause scarring. That was a good model to look at scarring. I mean, we see scarring from various conditions, from ulcers and injuries. And so, but this is a very reproducible model. So we were using PRK and PTK. And the way scarring occurs is you get a gene called TGF-beta, transforming growth factor beta, that then stimulates what's called connective tissue growth factor that causes these scarring. It causes collagen to get laid down, and it's a healing mechanism, but it can cause the eye not to see. And so we targeted CTGF. And so the first thing we looked at was, can you iontophoresis this into the eye? And so you can see here with these mice, you've got, and it's fluorescent dyed, so you can actually visually see it. And then you drive that electrical current, and you can see this material going from being in a mixture to driven towards, and you clip the negative, or depending on what material you use, either negative or positive on the ear, and you can see the material going into the eye, and then you can see that the eye is actually lit up, and not only is it lit up, it actually is in every layer of the cornea, and so you can use that to put material into the cornea that you want to treat. So here you can see a rabbit eye that has undergone PTK, and we're doing the same thing. We're using iontophoresis to drive this material into the cornea. And so what we used was an antisense oligonucleotide that basically prevented CTGF from working. And here you can see two eyes of one rabbit, and the left one, the image on your left, is the one that got a genetic material that was unrelated to scarring. And so you can see this robust scarring in the rabbit eye, and on the right, they had the antisense oligonucleotide, and you can see a much reduced amount of scarring. And here's several different rabbits, and you can see it's very consistent that the eyes that did not get the treatment had significant scarring, whereas the others did not. So this could be a potential treatment for, or pre-treatment for scarring after refractive surgery. The other way you can give material is by intrastromally injecting it. And it's just like giving a stromal hydration when you're doing cataract surgery. We use a 32 gauge needle, and you make a little bleb in the cornea, and that pushes the material past the epithelial barrier, so you can use larger material. And so what we used it for was HSV. And we would inject HSV. This was a non-replicating HSV. So it was HSV that did not have the ability to make more HSV. And you inject it into the cornea, it goes into the trigeminal ganglion, and then subsequently, if you challenge the eye with live HSV, you can see on the left side again that there is beautiful dendrites that the rabbit patient gets, and on the right side you can see this is an eye that has been treated with a non-replicating HSV, and that blocks the replicating HSV from getting in because it changes the milieu in the eye, or in the trigeminal ganglion. But it's not very practical to give people HSV to prevent them from getting HSV. And so there are other methods that we can use. And so to give these methods, you need something that can carry the material to the trigeminal ganglion, because it won't go to the trigeminal ganglion if you just put it in the eye. So there are various viral vectors that you can use. The big ones that we end up using are AAV, and lentivirus is used in some cases. They use adenovirus and HSV too, but those are less common. AAV is actually a very, very tiny virus. We don't really know what it does, but it's associated with several other viruses. And it's a very, very tiny virus, which makes it easier to enter into tissue, which is why it's used for a lot of these. The problem with it, of course, is it's very tiny. So you can only put genetic material that's a certain size into it. So if you want to treat something that's much larger, you have to use one of the larger vectors. Lentivirus is actually a really good vector, but it caused, in some cases, or it was associated with cancers in some of the children that got some genetic treatments for systemic disease. And so it's fallen into disfavor, though it's still used for some of the cancers therapies. And so what we focused on was ribozymes. And what ribozymes are are little tiny pieces of DNA material, genetic material that you can customize. So you can make it to match whatever it is that you're targeting on both sides. And then the central portion is the cutting portion. So it's almost like genetic scissors. It goes in there and it cuts the DNA or the RNA. And in this case, we're targeting mRNA. It cuts that. And then the little pieces, because they're not stable, are eaten up by the cellular machinery, and they're taken away. And so we used an AAV8 serotype, which is neurotrophic, so it attaches to nervous tissue. And so here you can see trigeminal ganglia, and you can see it's lit up with the AAV that we injected into the cornea. And then we actually loaded that AAV with the ribozyme that targets herpes simplex virus mRNA. And it's a part of the mRNA that helps it make more virus particles. And here again, you can see on the left side, they got just the AAV without any ribozyme in it. The right side, they got the ribozyme, and you can see that it protected the eye pretty well against HSV by injecting it into the eye. Now, you can also use it for corneal, for local corneal treatments, and you use a different kind of AAV. So we use AAV2 for this, and I think AAV4. But here you can treat the cornea by taking off a little bit of the epithelium. You don't take all of it off because you want the epithelium to actually get loaded with the virus. But you can see that the virus goes through every layer of the cornea, including the endothelium. And here you can see the epithelium is really nicely lit up. And so as you can imagine, for genetic defects like corneal dystrophies, if you can make or cut the mutation that actually is making the wrong protein in the eye, you can prevent that from causing the problems that you see with corneal dystrophies. There are some other innovative things that are in the commercial pipeline where they're taking AAV and they're putting a gene that makes either NGF or DAO and injecting it into the lacrimal gland. And because then the eye starts making its own NGF, you can use it for neurotrophic keratitis or for allergic conditions where this actually breaks down histamine and the body can treat itself without having to put medications which may be toxic into the eye. Perfect timing. How is that? So that's all I have. Thank you.
Thank you so much. We'll probably keep the questions for the end so that we're not late for the next set of speakers. The next speaker is Dr. Omkar Sawant. He's going to talk about the development of novel corneal storage solutions.
All right. Good afternoon, everybody. Thanks to organizers and especially Dr. Janzi for inviting me here to speak about some of the work that we are doing on developing more futuristic corneal preservation media as we are getting ready for upcoming use of cell therapy. I don't have any relevant financial disclosure besides I'm employed by Eversight. So a little bit background. Not sure if folks here know, but in April 2022 in United States, we had a big issue with availability of corneal storage solution. Prior to April 2022, we predominantly relied on Life Force as our go-to corneal preservation media. After that, they suspended their production and we had to use wide spectrum of different solutions using Optisol GS, Usol, Kerasave. We did also do a study on Cornisol that's manufactured here by Auralab. And during this time, we didn't know like when the next supply chain shortage was going to come. So we developed our own DIY corneal storage solution, which sometimes we call bathtub solution as well. One thing that we learned that we really need dextran 40 and chondroitin sulfate to make sure the corneal cells, the whole cornea doesn't swell too much and endothelial cells are happy. So while we're doing all this, fortunately, the supply chain shortage has gone away, but our efforts to develop new media continues. And while we were doing all this, we were thinking, why not develop a media that has Rho kinase inhibitor? As
most of you know, and I'm really preaching to the choir here, that Rho kinase enzymes are really essential to make sure corneal endothelial cell proliferate. They maintain the good integrity and suppress the apoptosis of that. And there are multiple clinical trials going on for ripasidil and netarsidil to use after DSO treatment or even as eye drop to see how that will affect the corneal endothelial cells. So our goal was really to see, can we develop a new corneal storage media that can promote the stemness or proliferative potential of not just corneal endothelial cells, but all types of cell within the cornea, including limbal epithelial stem cells. So the first part of the study, what we did, we recovered both corneas from research consented donors, and we randomly assigned one cornea in our DIY corneal storage solution that's shown here in the orange trace, and then the other one was recovered in corneal storage media with ROCK inhibitor, and we used fasodil for this study. So as you can see, at the day one, they all started at the same time with the similar parameter, but over the 14 days cold storage condition, we saw the presence of ROCK inhibitor actually help to keep central corneal thickness lower in the presence of those media. And here's a representative example. This pair started at the similar thickness, but by day 7, without ROCK inhibitor, it was at 538 micron versus the mate tissue, which was supplemented with ROCK inhibitor, much had thinner central corneal thickness. We also looked at endothelial cell density. As Dr. Patel was mentioning, it's highly selective and may not give the complete picture of functionality of the cornea. So we didn't see a whole lot of difference. Numerically, there were a higher density, but it did not reflect on statistical significance. So the interesting observation that we made when we were doing the study, not all mated pairs started at the same level. Especially for this pair, you can see the control had slightly healthier looking corneal endothelial cells compared to one that was randomly assigned with ROCK inhibitor. So we were pretty sure that this tissue will fall off from our study, and by day 7, it may not have any healthy endothelial cells. To our surprise, the one that we incubated with ROCK inhibitor had decent amount of healthy endothelial cells. So images here are from day 7, and the green cells basically indicate the cells that are live and functioning, and the cells that are red, those are basically apoptotic cells or cells that are on death pathway. So this kind of sparked the next idea: can we supplement the corneal endothelial cells on a stress parameter and then mimic a little bit of physiological condition and see how these cells will behave in presence of ROCK inhibitor? So what we did kind of tissue culture protocol. We took this protocol from David Elwith from Trefoil Pharma, and we mimicked their protocol where we took a donor corneal scleral rims, put them in 4 quarters, and then used diagonally opposite for the same treatment group. So each cornea had either control or supplemented with ROCK inhibitor, and then we also added EDU, which is a proliferating marker, ZO1 for the integrity of the cell, and then we stain all of the cells with DAPI as well. So you can see here in the representative example, 7 days later, incubation in the tissue culture media without ROCK inhibitor or with ROCK inhibitor, right next to the injury where there is a trauma, you can see the ZO1 staining that we observed was pretty punctate. And then in our ROCK inhibitor supplemented group, the ZO1 was really integral part of the endothelial cells, and it looked more functional. So we counted the ZO1 junction points in control versus ROCK inhibitor group, and we observe a higher number of ZO1 junction point in ROCK inhibited treated group. We also look for EDU. In our hands, we didn't see a whole lot of proliferation. Again, these cells, they were under tissue culture media, but did not have a lot of growth factor. But we did see few EDU positive cells in our ROCK inhibitor treated group. but not enough to quantify. So the next question we wanted to ask was, in relevant to eye banking and corneal transplantation, can we minimize the stress and trauma that happens at the time of tissue recovery, that happens at the time of DMEC, DSEC processing, to really program endothelial cells in such a way that post-operatively they will have better outcome. So we kind of did our like a decimase brushing protocol, where we do a central 4mm punch, as shown here, and then brush off without doing anything to decimase membrane. So you can see on day 0, there is quite a bit cell loss in central 4mm, and then we evaluate the tissue 7 days later. As you can see, there is a little bit regeneration even without the drug, because this is supplemented under tissue culture media. But we saw much higher regeneration if you supplement the tissue with ROCK inhibitor. So in general, we saw about 10% regeneration without doing anything, but you can really boost that regeneration up to 25% if we supplement the tissue with ROCK inhibitor. We also looked at overall endothelial viability. So between day 0 to 7, there is a natural tendency to have less endothelium viable, but in a ROCK inhibitor treated group, we saw actually that loss was kind of balanced because of the treatment. Then we went one step ahead, which was quite irrelevant for eye banking operations, but we wanted to see the decimase stripping only protocol. So what we did the central 4mm punch, but in this time we completely stripped off the decimase. And in that case, we saw a drastic day and night effect. The sample size is a little bit thin, and we're still figuring out what's going on. And reason I put question mark here that we see such a huge regeneration, but we don't know whether this is regeneration of endothelium or something else, such as mesenchymal cells or something else. So we still have to figure out the identity of these cells that are regenerating. Now I'm going to abruptly switch gears a little bit here and talk about limbal epithelial cells. What we saw is there is a quite decrease in viability of limbal epithelial cells in corneal storage media that are currently FDA approved. So most of these cases are in Optisol. So by day 7, we see quite a bit decrease or almost to 0 for the limbal epithelial cells that are expressing p63 alpha. Interesting observation that we made, there was an outlier. So it was like, why this particular time point was not at 0%. So we looked a little bit closer and made an observation. We did another independent study with 6 different donors from Caucasian and non-Caucasian population, that we see if you have donors that are pigmented skin type, they actually have higher p63 alpha positive limbal epithelial stem cells. So now we are like trying to reinvent what is required for limbal epithelial cells, so we can use the donor tissue for allo-select type of procedure, and then work we are doing in collaboration with Vivian at University of Houston. Hyaluronic acid is one aspect we are trying to explore. So in summary, what we see is perhaps maybe there is a need to supplement corneal storage solution with Rho kinase inhibitor, looking at where the future of endothelial keratoplasty is headed. And we see that limbal epithelial cells tend to lose their stemness in current corneal storage solution. So maybe perhaps using non-Caucasian population might have better survival of limbal epithelial cells. So with that, I just want to thank our funding sources and our collaborators and the team at Everside. And again, thank you for this opportunity to present the work here. Thank you.
Thank you. I'll have the next speaker, Dr. Shizuka Ko. She's going to tell us about the dynamic optical quality with contact lenses. In the meantime, are there any comments from the panelists? Okay, Dr. Ko.
Thank you, Vishal. So, good afternoon, everybody. It is my great pleasure to give a talk at the CARICON and ECLA Joint Symposium. Okay. So, safety, comfort, convenience, and quality vision are important factors associated with contact lens wear. So far, contact lens manufacturers have been making a lot of effort to archive safety and comfort. Since most of the contact lens wearers have satisfactory visual acuity with contact lens, so less attention has been paid to improve quality visual performance with contact wear so far. Also, it is partly due to the difficulty in evaluating on-eye optical quality with contact lens. Let me share with you the recent data of international contact lens prescribing data. Actually, it is published every year in January. Right now, soft contact lenses were prescribed in 86% all over the world. And after the launch of silicone hydrogel, its market is growing. So as you know, I believe most of you are familiar with contact lens discomfort, CLD. According to the CLD report from IOVS, it is defined as a condition characterized by episodic or persistent adverse ocular sensations related to lens wear. Once a contact lens placed on the eye, tear film is divided into two components: pre-lens tear film, and post-lens tear film. Pre-lens tear film has a important role to determine the front surface readability of the lens. And post-lens tear film is important to provide ocular comfort, cushioning the contact lens against the ocular surface. For the successful contact lens wear, both pre-lens tear film and post-lens tear film are important in maintaining ocular surface. So this is a simplified mechanism of CLD. So uneven tear distribution and increased friction are the main factors for the soft contact lens wear for CLD. So contact lens dry eye questionnaire 8, CLDQ8, is an efficient means of consistent CLD assessment. It is widely used all over the world. So it is reported to reflect the overall opinion regarding soft contact lens performance. It consists of 8 questions: frequency and intensity of eye discomfort, eye dryness, and changeable blurry vision, and frequency of coping action like closing eyes or removing contact lenses. Original CLDQ8 English version is developed by Dr. Robin Chalmers. So, but because in Japan, so far we didn't have such kind of unified tool. So I actually worked with Robin and developed the Japanese version of CLDQ8. It's named as JCLDQ8. Actually, I try to actually show you the JCLDQ8 can differentiate contact lens wearers with different overall opinions of their contact lenses. Like cutoff value in US is actually less than 12, but in Japan, cutoff value is 11, less than 11, kind of similar. It works. So in our study, we found that 70% of soft contact lens wearers have changeable blurry vision. So vision is not static, always changing. So this is a pioneer study about the optical or visual impact of tear breakup. Actually, this is published in more than 20 years ago. And in this study, subjects are asked to actually wear soft contact lenses and keep their eyes open for more than 1 second, or 1 minute, 60 seconds. So you can see the kind of tear thickness changes by retroillumination, and also you can see the remarkable changes in vessel contrast in the retinal fundus. So, inspired to that study, we also come up with a continuous assessment of visual function related with tear film. Sequential wavefront measurement is one of the continuous assessment of visual function. Shown here, the sequential wavefront measurement samples from normal eye and dry eye with Sjogren syndrome. So when we measure the wavefront aberration right after the blink for 10 seconds. So shown here the the retinal image high order aberration maps and simulated retinal image for every second. So in the normal eye, this eye has a stable retinal images, but dry eye has actually, you can see the visual deterioration after the blink. So recently published contact lens evidence-based academic report by ECLA, it says there are risk factors for CLD. They can categorize into three. So contact lens related and patient related and contact lens modality. We can focus on material from contact lens related. So actually, there are some these reports are still actually controversial. Okay, let me revisit the history of the contact lens. So soft contact lens was first invented more than 60 years ago. So in 1961. So after that, the hydrogel contact lens are main. So from 1980 to 2000. So silicone hydrogels actually first come into the market in late 1990s. Then after that, right now the silicone hydrogel is actually the mostly actually prescribed rather than hydrogel lenses. So actually, so even for hydrogel, contact lens manufacturers are making a lot of effort to improve the wettability. So this is we actually previously to see the effect of wetting agent of contact lens hydrogel contact lenses. So we measure the wavefront aberration with the contact lens, hydrogel contact lens wear without PVP. This is internal wetting agent of contact lens. So without PVP and with PVP. So you can see the visual deterioration. So without PVP, but contact lens with PVP can provide stable vision. When we compare the different materials, so hydrogel versus silicone hydrogel. So when you see the wavefront maps and retinal images for hydrogel, you can see the kind of unstable and actually deteriorated impaired visual acuity. Retinal image, but for the silicone hydrogel lens, provide a stable and better image quality. We recently published the impact of wetting agent and material both. So you can see the visual retinal image quality is actually much better with silicone hydrogel with wetting agent. So ECLA actually clear actually report suggests for the contact lens users with CLD. So effective strategies to improve CLD is to switch lens care products and change into a daily disposable modality. So again, safety, comfort, and convenience and quality vision are important factors associated with contact wear. And especially ocular surface and tear film actually affect comfort and quality vision. So this is a summary slide. So 70% of contact wearers have changeable or blurry vision. Material or internal weighting agent of contact lens can affect on eye dynamic optical quality during contact lens wear. Thank you for your attention.
Thank you, Dr. Ko. The next speaker is Dr. Divya Shrikumaran. She'll talk on vaccine-related graft rejection.
Good afternoon. I'd like to thank Dr. Janji and the organizers for the invitation to speak today. So as we all know, corneal graft rejection is a leading cause of graft failure, and the rates in the peer-reviewed literature range from 0% to over 35% based on the case series. We know from the cornea donor study and the CPTS study, many of the factors that affect graft rejection include the type of keratoplasty, the indication, the neovascularization levels, comorbidities such as glaucoma and ocular surface disease, race or sex, among many others. Another factor that has received some attention in initially some case series and case reports was graft rejection in the setting of vaccination. And there's a temporal association in these case reports, but no causal mechanism has yet been proven. Now, with the COVID-19 pandemic, widespread vaccination for the SARS-CoV-2 virus has renewed concerns, and indeed increasing reports of graft rejection associated with vaccinations have been reported. Now, many of these cases were successfully treated with topical or systemic steroids, but graft failure can occur in this setting. And the mechanism, again, is unknown, but it's presumed to be a cross-reactivity between the viral antigen and corneal endothelial cells. So in this survey that was conducted early in the pandemic, 1/5 of corneal surgeons responded that they had clinical experience with vaccination-associated graft rejection. And when they were queried about their approach to advising keratoplasty patients that are eligible to receive either the influenza or zoster vaccines for patients that had either high or low risk for rejection at baseline, there was a lot of variability in their responses as to how they would advise patients. Overall, 46% of the time, they recommended vaccination without any modification. But up to 22% of the time, they recommended delaying vaccinations. And this was typically in the setting of a high-risk graft with recently performed surgery. So just now that we've had a few years of COVID-19 vaccinations available, I'm just wondering how many in the audience and on our panel have seen a patient with vaccine-associated graft rejection? So several. So more than 20% of our panel have seen it now compared to when this survey was performed. And how do you tend to advise patients that are post-keratoplasty regarding the receipt of vaccination? Is anyone delaying vaccination? Do you typically recommend vaccination with no change in their current therapy? Recommend some prophylactic steroids to all patients pre and post? So we have a couple hands raised there. And then how about recommending steroids more selectively based on the patient's risk for rejection? So a couple here. So still some variability, and I think it's understandable given that the data that we have to help make our decisions on this are contradictory. So I'll review some of the data that we have, and maybe we'll have a little bit more clarity by the end. So this is the largest case series that was published by Dr. Janji and Dr. Jang, part of our panel group here. And they evaluated the CDC reported reports to the CDC's vaccine-associated adverse events reporting system. And in this, 55 eyes of 46 patients were diagnosed with graft rejection following SARS-CoV-2 vaccination between December 2020 and July 2022. Amongst these cases, 62% had a PK. But interestingly, in patients that had EK, the patients presented with rejection earlier or had symptoms earlier than they do in PK eyes. What the authors acknowledge, however, is that while we have a large number of eyes, we don't have a control group to know how many patients with vaccinations and grafts didn't develop rejection. This is another case series from Japan that evaluated and compared 124 non-vaccinated DMEK patients to 74 vaccinated DMEK patients. They found 1 episode of rejection in non-vaccinated patients, but 5 in the vaccinated group. And so in a model that adjusted for factors that affect vaccination, sex, age, laterality, indication, and topical steroid use, they found a 25 times higher risk of rejection in patients that received vaccination. Now, the number of eyes and sort of the absolute small numbers numbers of episodes of rejection kind of make you wonder whether there's any confounding variables that were not accounted for here. As we can see from this other contradictory report, we find that in large population-based studies in both the UK and in Italy, they evaluated the rates of patients presenting for emergency visits for graft rejections, both pre and post availability of COVID-19 vaccinations, and found that there was no real difference in 2021 after many patients had received vaccinations. However, in this report, this is just a population-based study, so we don't know what the prevalence of vaccination amongst patients with keratoplasty in this region actually was. So our group tends to look at big data sources, real-world evidence, and so we've evaluated this in Medicare claims and both using Kaiser Permanente EMR records as well. And I wanted to share some of that data, which is yet unpublished. We looked at amongst Medicare beneficiaries, and for those of you in the audience, Medicare is a government-funded healthcare insurance for patients that are over the age of 65. So it's a large database of claims from their care. We identified over 30,000 patients that had a history of a corneal graft and had received COVID-19 vaccinations. And as you can see, within 3 months, the incidence of new rejection was 0.44%. There was no significant difference in the 3 to 6 months following vaccination as well, as you can see here. And for influenza, in over almost 24,000 patients, there was a rejection rate of 0.18% within 3 months. So these are pretty low rates. And for patients that are over the age of 65 and thus at higher risk for both mortality and morbidity from flu and COVID, it argues that widespread delaying of vaccinations and or avoiding vaccinations in this group may not be warranted. We further evaluated what some of the high-risk groups were, though, for developing rejection, since there were some cases. And you can see here that PK versus EK had higher rates of graft rejection. Patients that had, this is true for both COVID-19 and influenza vaccines, and patients who had COVID vaccinations that had a history of prior graft rejection were also at higher risk than those without a history. So high-risk groups, again, are the ones that we already know to be higher risk for rejection in general, patients with PKs compared to EKs and patients with prior history. We also evaluated time from keratoplasty to presumed COVID-19 vaccination-associated rejection, and we found that 88% of the cases occurred 1 year after keratoplasty. So this corresponds with the time when patients are likely to have either discontinued or decreased their steroids significantly. So whereas our survey had demonstrated that most surgeons were recommending delaying vaccination shortly after surgery, this data suggests that perhaps the highest risk is going to occur later in their post-keratoplasty timeframes. So switching gears to talk about the Kaiser data, we found in a retrospective case control study of graft recipients between 2008 and 2022, there were 600 cases with a patient that had a single episode of graft rejection, at least one episode. And we compared these to 1,800 controls, and these are patients without graft rejection, and they were matched 3 to 1 based on age, sex, and transplant date. The proportion of patients that had prior vaccination within 12 weeks prior to their episode of rejection was about 23% in the cases, and 22% of controls had a vaccination within a similar time frame, showing no increased risk. Shown differently, here is a multivariable model that shows that regardless of whether you look at any type of vaccination, multiple vaccinations, vaccination types, mRNA-based vaccines versus others, when you adjust for their baseline risk factors like corneal transplant type, indication for the transplant, race, ethnicity, and overall health status, amongst other factors, there's no association between receiving the vaccination and rejection. So in summary, our larger cohort data don't demonstrate any association of vaccination with graft rejection. So avoidance of vaccination is not really advisable, especially in high-risk groups with regards to mortality and morbidity from the underlying disease process. So we have to be careful how we message this when we speak to our patients. We obviously need to counsel our patients that graft rejection is possible and that make them aware about our symptoms of graft rejection so that they can present promptly for care, but we have to be careful how we word this and deliver this message so that they don't contribute to vaccine hesitancy. And then the overall low rates do not warrant pretreatment in low-risk keratoplasty patients, but a more nuanced approach to high-risk patients may be beneficial. Thank you. I'd like to acknowledge some of my collaborators for this work, and thank you.
Thank you. Thank you, Dr. Shivakumaran. The last speaker of the session is Professor Benny Jeng, the president of the Cornea Society. And he'll be talking to us about neurotrophic keratopathy. Thank you, Professor Jeng.
Thank you, Dr. Janji, for the invitation to speak. I'll be talking briefly about neurotrophic keratopathy today. I had no relevant financial interests. And I'd like to start out this talk with one of my favorite patients of all time in my 20 years of practice. This was a then 60-year-old gentleman with diabetes who was doing fine, and then he had complicated phaco cataract surgery in his left eye at an outside facility, had to undergo a pars plana vitrectomy for retained lens fragments. After that, things went downhill, and he developed a non-healing epithelial defect in August of 2015, and then was referred to me. We did the standard therapies of withdrawing medications, preservative-free topical artificial tears, soft contact lens, autologous serum, and he refused anything more intensive. He didn't want a tarsorrhaphy. He didn't want a scleral lens or anything. And so we battled with him, and he ultimately developed a combined Caranibacter and a mycobacterial keratitis in December 2015, and then required a PK because of non-responsiveness to medications in April of 2016. So, of course, now he was neurotrophic to begin with. He had a PK, and now he has an extra neurotrophic cornea, if you will. And for 2 years, we battled with him because he refused to have a tarsorrhaphy that I thought was necessary to help him. And he failed all the other therapies. This whole entire time, just so you know, his other eye, his fellow eye, was 20/20. Okay, we'll come back to his other eye in a moment. But after 2 years of battling with him, this is ultimately what his eye ended up looking like. Now, you can see we might have been able to save this if we would have intervened in other ways, but he didn't want anything. And so I show this not to show you that, unfortunately this happened to me, but this can happen in cases if we don't aggressively treat these patients. So what is neurotrophic keratopathy? Well, Harmon Dubois actually has a really good definition of this, calling it a disease related to alterations in corneal nerves leading to impairment in sensory and trophic function with consequent breakdown of the corneal epithelium, affecting the health integrity of the tear film, epithelium, and stroma. So the most common causes of NK are herpetic infection, diabetes, cranial neurosurgery, chemical or thermal burns. There was a really good study that was done out of the IRIS registry, published in the Blue Journal just recently, identifying also the most common causes being herpetic keratitis and diabetes. And NK has a prevalence in the US of approximately 21 cases per 100,000 patients. And so that's about 60 to 70,000 cases of people in the US with NK, which is a lot. The issue is at the time of diagnosis, if you look in the chart, their vision has already gone down from prior. And so the key here is to try to identify these patients earlier so that we can get to them before they start to lose vision. So how do we do that? Well, obviously, the hallmark of making the diagnosis is corneal sensation testing. But we also need to recognize that if we don't ask the right questions in the history, and we don't take a good clinical examination, we could miss this and then not do corneal sensation testing. The symptoms, if you just ask the patients, are rather nonspecific, and they might be suggestive of dry eyes, except for the fact that the symptoms actually get less with worsening disease, of course, because they can't feel it. So we had to be diligent about asking the right questions. If you have confocal, you might see something like this, where in frame A, this is the normal subbasilar corneal plexus, nerve plexus, and then in B, C, and D are stage 1, 2, and 3 of the Mackey classification of neurotrophic keratopathy. So what is a clinical appearance? Well, stage 1 is where you get lissamine green staining of the inferior palpebral conjunctiva, decreased tear breakup time, increased mucus viscosity, and this punctate corneal epithelial fluorescein staining. To me, this central staining is quite characteristic, but if you just look at it really quickly and you look at the conjunctival staining, you can see how people can misdiagnose this as dry eye and just start to give artificial tears without recognizing that this is very early NK that can lead to vision loss later. So the treatment for this is very similar to treating dry eyes with the topical anti-inflammatory therapy, the artificial tears, punctal occlusion. But I think it is very valuable to be able to make the distinction so that you can get to the NK patients earlier. Because if you don't, they'll develop into stage 2, which is where they develop the epithelial defect. These edges become thickened, smooth, and rolled, have trouble healing. There's stromal swelling with Descemet's folds, and they can actually have AC inflammation as well. When you get to this phase, then we're treating this non-healing epithelial defect with preservative-free topical antibiotics. We worry about melting, and so you might consider preventing the melting with either macrolide antibiotics or tetracyclines or sodium citrate. You could try to debride the edges or non-surgical eyelid closure, or in more severe cases, tarsorrhaphy, surgical closure. I reserve conjunctival flaps for eyes that have low visual potential. Other treatments such as serum, scleral lenses, I find personally very effective, amniotic membrane as well. And then there's the 2 newer ones, recombinant human nerve growth factor and corneal neurotization, which I'm going to spend a little bit of time talking about. So this is the phase 2 randomized double mask vehicle control trial looking at recombinant human nerve growth factor that was published in the Blue Journal. You can see that in the higher concentration that is now commercially available, distinctively and definitively more success than the vehicle at decreasing the size of the non-healing epithelial defect. And if you look at this one, which is the multi-center randomized vehicle control pivotal trial, it demonstrates the same thing. But I want to draw your attention to the fact that it is not 100% effective. So if you look at this group of individuals that were selected for this study, 65 to 69% compared to 16 to 29% is very convincing compared to the vehicle, but is not 100%. So even in this population, you have to realize a third of the patients probably aren't going to respond to this medication. And then what about corneal neurotization? Well, this was the seminal paper that most people in ophthalmology quote, describing 6 patients that they did direct neurotization, which when this was published, I looked at it, I said, this is crazy. I can't understand how this could possibly work. Well, apparently it does. But before we go into it, I just wanted to give due credit that was not the first instance of doing corneal neurotization. The first attempt at this was actually back in the early 70s, or maybe even late 60s, by a neurosurgeon, Dr. Sammy, who tried this on a 12 or 13-year-old child who had bad orbital trauma, and he tried to do an indirect corneal neurotization. So in the ophthalmic field, it was in 2009. And so what is this? This is where the contralateral, as originally described, supraorbital and supratrochlear nerves are dissected from the forehead, brought underneath the bridge of the nose, out through the eyelid onto the ocular surface and implanted by the limbus. As originally described, there was also an indirect method that could be used, and that's the picture on the right in the yellow, where you take a conduit, either a sural nerve or greater auricular nerve, or even acellular cadaveric nerve as a conduit, so you had to do less dissection, and you can use that to conduit onto the other side. Since then, there's lots of other ways of doing it. You can even do the ipsilateral side, where you just dissect it out and bring it down onto the ocular surface. And this paper just shows the different types, if you look at the bottom right-hand corner, the different types of grafts that can be used: sural nerve, cadaveric nerve, even greater auricular nerve. And then when we talk about stage 3, this is where the non-healing defect has become stromal lysis and melting, and actually may result in perforation. So I think the management of this is pretty straightforward. If there's melting, you do amniotic membrane with a tarsorrhaphy. If you need to, a corneal graft, and certainly if there's a perforation, you may need to glue them and then do a corneal patch graft. I just want to draw attention to the fact that the neurotrophic keratopathy study group has recently this year published in the Ocular Surface a new classification scheme instead of the Mackey scheme with 3 stages. This has 6 stages, and notably the important thing is that they identify stage 1 as altered sensation without keratopathy. So they're recognizing that we need to actually identify these patients before we even see any findings on the surface, because that is when we want to get to them so that we can prevent sequelae. So just real quick, back to my patient, who, remember, was 20/20 in his other eye. He actually developed 2 weeks of vision loss in this good eye and didn't do anything about it. and he came in with a macula-off rhegmatogenous retinal detachment that required pars plana vitrectomy, sclerobuccal, and silicone oil. And of course, after that, he developed a non-healing epithelial defect. I put him in a clinical trial that I was doing at the time. It didn't work. I did a permanent lateral tarsorrhaphy, which he finally let me do. But unfortunately, he still had this defect. And at this time, recombinant human nerve growth factor was out, so I put him on one round of that, and it got smaller. And then I put him on second round, and unfortunately still opened up again. So at this point, we actually did neurotization for him. He is about 3 years out now, and he has developed better sensation, but he still has not fully closed all the way. And I show you this study to show you that the response to healing in terms of corneal sensation is very variable. Sometimes people get a lot of sensation back very quickly. Sometimes they never regain a ton of sensation, and it takes a long time to do it. And why is that? It's because everybody's a little bit different, and we think that the longer the denervation has been present, then the worse the outcomes after neurotization. And we also know that despite sensory improvement, many eyes may still experience epithelial breakdown. So in conclusion, NK is a challenging condition, as you can see with this patient. It can have serious consequences. We do need to try to diagnose these patients earlier. Therapies have evolved significantly over the last 2 decades, and I think that corneal neurotization is actually a very exciting surgical option. We just need to know a little bit more about which patients are the right ones to do it and when we should do it to get them quickly. Thank you very much.
Dr. Jain, thank you. Any questions, any comments for any of the speakers or from the panelists? I want to ask Dr. Thuli, what is your PRK model, and when do you start the treatment? Do you use the Cornell Hayes model is the PTK? I can't hear you. When do you start the treatment?
I said, no, so it was a PTK model, and it's a rabbit, but they are 2020 now. So, no, I'm kidding.
I'm sure they're 2020 after, not before. But do you start the treatment immediately?
Oh,
after
I'm sorry. Yes. So we do the PTK and then give the iontophoresis right then.
Okay. For Dr. Srikumar, so I know, we worked on a large data set as well, and you did as well. What I feel overall, and this is the general consensus, the risk of starting steroids before and after vaccination is so low that's difficult to choose patient groups to tell them you're low risk, you don't need it, and you're high risk, you probably need it. So that's why we still start steroids irrespective of what we found. And we also looked at the risk of zoster post-vaccination as well. So do you think the same?
I think that for some patients that are have pressure issues and everything, there's that small risk of increasing their steroids to a higher level, but it's more so compliance too with some patients. Trying to get everyone to start a new regimen and then adjust it back sometimes is tricky as well. So I think there's challenges to both ways, but the ones who probably need it are the ones that you're most hypervigilant about anyway. It's such a low risk overall. And I think the bigger issue, frankly, is what I was trying to get at, is that if we talk about this with all people and then some patients aren't getting their vaccines, that's the messaging that we have to be careful with, because I think we see probably a lot of vaccine hesitancy in patients anyway, or at least I do in my clinic. And so I'd hate for them to take home that they shouldn't get a vaccine.
Sure. Well, yes, please.
I was going to ask a follow-up question to that. But so you looked at your 2 groups that you saw that didn't have a difference, but you used 3 months as the cutoff. Most of the presentations have been within 2 weeks to 3 weeks. You think looking at that might or have you looked at that?
We did a sensitivity analysis with a shorter time frame, but there were some reports that went out as far as 8 weeks. So we thought that having a larger time frame was a little bit better to catch more people. But we did a sensitivity. Yeah, but with 8 weeks, it wasn't different. So we didn't do a 2-week window, because even the VAERS data that it was 30 days is for what most of the patients were. So going that we were with on claims, we wanted to have a longer time frame.
Yeah, Dr. Divi, I just want to follow up. I think that's probably the most definitive evidence that I've seen. When you do start, or when you do treat a patient, what what exactly, how much are you treating them with, and what's your regimen?
So for the patients that I'm concerned about, I mean, I will say, first of all, I have all of my patients, even EK patients after a year, still on a daily dose of steroids. So I'm not stopping steroids. And I think that probably it's a bigger concern if your practice is to stop steroids. Other than phakic patients, I usually keep them on like a Predforte a day or a Lotamax. And so for patients that are high risk, I usually would start 2 weeks before, 4 times a day, and have them taper off after the vaccine. Do it through 2 weeks after, and then start tapering back down to their once a day.
And if they're on low to prednisone, if they're on a low dose steroid, do you increase them to prednisolone?
I usually go to prednisolone acetate. Yeah, prednisolone acetate 4 times a day, 2 weeks before.
Is that what everyone else, Benny, do you do the same thing?
I do exactly the same.
Exactly the same thing. I know Professor Kinashid and I, we discussed this a little bit when we were in Canada earlier this year, that you've seen a few cases as well. Okay. Dr. Gupta, can you give us the Indian perspective? Because the vaccine was different. You have a different population. The hesitancy is not that much. It's a different kind of hesitancy. Did you see a lot of cases?
Not a lot of cases, but I do recall a couple of cases, and they happened after the COVID vaccination. And I was just talking to Dr. Divya that I feel that the clinical features of rejection, they may be different. So if we study the 2 cohorts of vaccine-associated rejection versus non-vaccine associated rejection, maybe the clinical features, the presence of the pattern of KPs or the inflammatory reactions or how they respond, they may be different. But currently in my setup, I just don't have those many number of patients. So maybe practices which have more patients like this, I think, and my response of the patient to the treatment was very good, but she had a graft failure. So I don't know. But in my experience, it responded very well to the steroids that we gave. But I think it needs more cases or people with more experience to tell that.
Actually, just to clarify, the case of failure I was talking about was a patient that had COVID-19 infection. So I actually haven't seen vaccine-related rejection myself, but I did have a patient who came in after having had COVID infection who had a graft failure.
Dr. Lal.
Yeah, I have a question. How long does it take for an episode of rejection to manifest after vaccination so that we know that we are more careful around that time period? Is there a duration that we have after the vaccination that we look out for an episode of rejection?
So Dr. Janji's data showed that most of the cases were coming in within 30 days, having symptoms within 30 days, may not be presenting by that time. Symptom onset is, and a lot of the times the symptoms were things that a patient would notice, blurry vision, and light sensitivity and pain. So it would be, if we educate them on symptoms, then hopefully they would present early.
And that is from a large database. So none of us will have a bunch of cases to tell any difference. But yes, this is from a registry. So that's all we know for now.
Thank you.
Anything else? Any other questions? Well, this is going to be a good group. We're going to finish on time.
I have a question to Benny.
Yes.
I think what I have heard is the use of the NGF. In the United States, there are many, I think, that the patient they are receiving the NGF treatment, but not much in Europe. It's because of the expensive drugs. Is that true?
That is true, actually. I think that the cost is very high, and the UK actually did a study looking at the cost effectiveness because it's so expensive and that it's not 100%. And in fact, if you just throw it at everybody, the success rate is actually quite low. So they actually don't recommend it as a therapy. It's published.
Yeah, I mean, in the US, and correct me if I'm wrong, what I've seen in my patients is when they reopen after the first round of treatment, it's very difficult to get the insurance to pay for the second round of treatment. So there's a lot of paperwork required. It's not easy to get that treatment, very expensive in the United States as well. But tarsorrhaphy works the best, as always, if the patients are willing to get that done.
Yeah. As a follow-up to that, I know there was a paper in ophthalmology about using, nerve growth factor for stage 1 NK, and I wasn't sure if anyone on our panel is treating stage 1 patients.
So I know, please.
Well, I haven't done it because
it's hard enough to get stage 2 patients to be covered by insurance. And so this would be really, really difficult. I have treated a patient, I wouldn't say prophylactically, but they're neurotrophic and they're having a PK. And I got insurance to cover them immediately after the PK to prevent anything.
Well, if it makes everyone feel better, I think there are quite a few drugs in the pipeline now. Dr. Jeng is PI for a couple of them, and we are a site for them as well. Yeah. So let's see what the future holds for NTK. Well, thank you very much, all the panelists and speakers, and thanks a lot for the audience for staying back. Thank you.